thermal lid massage, so heated massage, built-in 2-minute timer. It's 2 minutes per eye. Again, easily performed by a tech. This is external, to the eye. Step 3 is the expression where we're able to really clear out those glands. And obviously these first two really help with this third. And again, this is 2 minutes, I would say, and you could have your tech do this as well, although a lot of docs like to do it because it's really kind of the payoff step here. So I want to now show you a real quick, this is like a 1.5 minutes, but I know it's hard to visualize maybe this in use. So I just want to give you this quick look at these so you understand which each step is. And then I'm going to turn this over to Dr. Valdez, who's really going to dig deep into these, into the kind of the state of treatment and disease in this disease space. So here we go with the video. So you are going to want to use some proparacaine drops just to kind of calm the nerves. So here you can see debridement on the upper lid. Just kind of a dull golf club spud. Thermal massage, you're going to use some ultrasound gel just to help transfer the heat and reduce friction. It's got a built-in 2-minute timer. It's very comfortable. I've had it done 3 times myself. Thermal expression. So here we are, the red expressor, the paddle, the external paddle is heated. The blue, the internal is not. So we're keeping heat. And it's easy to treat both the upper and the lower lids. You can see those angles make it very easy to get into those lids. Again, a couple drops of proparacaine before you do this. I think you're going to see a close up here. Yeah. You just want to get those paddles about 3/4 deep, at least, into the eyelid. And then it's pressure limited. So you're not using a ton of pressure to express those glands. It's less than 10 PSI. So again, comfortable for the patient. And since we've debrided and we've heated that meibum, it's easy to express. Oops, we don't want to watch that again. Whoops. Okay, so without further ado, we're making good time here. It's really a treat and an honor to have Dr. Valdez here today. You can see his biography there. It's much too long to read because he's so accomplished. I'll just read kind of the top 3 bullets and a couple of highlights here. Dean of School of Medicine in Monterrey, Mexico, Director of Cornea and Refractive Surgery, Director of Advanced Therapies and Visual Science. He's the president, or has held the president of the Mexican Society of Ophthalmology. He's won awards for International Ophthalmologist of the Year, and over 120 publications, 5 books and 8 chapters. So I think when I was talking to one of his staff at Arvo this year, I think he summed it up best when he said, he's the Michael Jordan of ophthalmologists in Mexico, right? So I thought that was really good. So without further ado, I'm going to turn it over to Dr. Valdez.
Okay.
There's one microphone open.
There we go. Someone's got their mic open. Yeah.
Okay. Okay. Thank you, David, for this kind introduction. Very nice from your part. Can we show the next one?
Yes. Whoop. I'm controlling.
So we were talking about our first early experience, because we just got the MGrx, and so we will show you this case series pilot study that we just start to know this device. But I can tell you in advance, we are very happy. We have been working in this, and I will show you the different studies that we have. But this this new device has a special place in our strategy to treat Meibomian gland dysfunction. So just a quick introduction. Dry eye disease, you know, is a very common ocular condition. Prevalence from 7.4 to 33%, and probably higher here in some areas of northern part of Mexico. That's pretty similar to south part of states. There's very dry, low humidity around us. We can organize the dry eye disease in two functional categories: aqueous deficient and evaporative. So we will focus in this last one in this talk. To be effective, a treatment should be aimed at the underlying etiology. Can we go back a little? Yeah,
Yep.
thank you. Aqueous deficiency, dry eye, of course, the production is insufficient, but we were talking about evaporative dry eye disease. And this is due to the instability of the tear film, and this is due to the Meibomian gland dysfunction. So let's focus on this Meibomian gland dysfunction. Next, David, please. We know pretty well that, for example, age increased dry eye symptoms, and we see in our everyday clinical work here that has as the age increases, we have more symptoms, and probably due to, if you have patients in a large city like us here in Monterrey, it's a 5 million city with a lot of pollution, dry environment. We actually have really a lot of patients who complain about dry eye disease. Next, please, or at least have dry eye symptoms. And we know that around 80–90% of patients with dry eye disease have a MGD, Meibomian gland dysfunctions. And for this specific patient, conservative treatment as the lubricant drops and ointments or gels, low-dose anti-inflammatory topical medication, and warm compresses is not enough. It's insufficient to control the signs and symptoms of dry eye disease. So in response to that, we have from the industry a lot of in-office technologies that the purpose of those is to provide a long-term relief from the symptoms of dry eye disease. Next, please. Yeah, thank you. We can define Meibomian gland dysfunction as a term to use to describe a group of disorders, both congenital and acquired, linked by functional abnormalities of the Meibomian gland. MGD can lead to altered tear film composition, ocular surface disease, ocular and eyelid discomfort, and as we already talked about, evaporative dry eye. Next, please. So MGD has been classified as a low delivery and with Meibomian gland hyposecretion or obstruction, quite common. And the other is the one that is hypersecretion. We can divide this or split these entities and into primary and secondary causes, as you can see in the slides. And but I will say the main number of patients, the majority of patients, come from this obstructive Meibomian gland. This dysfunction is due to this hyposecretion, and the origin is that it is obstructed. Can be by scar tissue or can be by the same the change in the lipid composition. Next, please. So getting into pathophysiology, MGD is a highly complex disease condition that is associated with several or is caused by several for example, host, microbial, hormonal, metabolic, and environmental factors. But the main, I would say that if you see the slide in the center is obstruction, but that can, as I mentioned, can be generated by changes in the meibomium. It can be in the quality that changes the composition or the quantity, and that can, well, that will at the end create a deficiency in the tear film and an unstable tear film that allows a rapid evaporation from this cornea surface, creating all these symptoms of dry eye. Many factors around that can affect and create these Meibomian gland dysfunctions. It's not it's associated, for example, with demodex, for example, or inflammatory diseases, but other causes can produces like any contact lenses, and even, and I will talk a little bit about that, refractive surgery. Next, please. So how we approach this? Well, the dry eye disease, we have a systematic approach in the diagnostic strategy, has been discussed and several have been proposed. The last one is from the Deuce study, but I like this slide that shows all the different approaches according to what we are finding. And I would like to bring your attention to if we see lid margin disease and blepharitis. If we see that, we must focus first on that and try to work on that. Obviously, in our practice, we do all the office, I would say, slit lamp evaluation with Schirmer. We put the Lisamine green and all the dyes that we normally use. We even measure the lacrimal meniscus. We do meniscometry of those patients. But we also focus on the Meibomian glands. Next, please. So, for example, we conduct this study about the evaluation of mammography scores as age increases in Hispanic patients. This was a retrospective study, case series 192 records of patients diagnosed with dry eye disease. And what we have found is that mammography scores tend to get worse with the as I already mentioned, the passage of time, such a different mammography score between those younger than 65 years and those older. This may suggest that changes may also accelerate after certain age. So we need to take more, detailed examination in older patients, because we will, for sure, we will find some alteration in the Meibomian gland structure. Next, please. And also, as I already mentioned, we conduct also this study, the correlation between ocular surface disease index and the dry eye functional parameters using non-invasive method. In this case, and I think, David, you mentioned in the introduction, we use the keratograph 5, and it was very accurate in correlate what we do in the office, and according to that. So we systematize the approach for the patient with dry eye disease, and we are, have a suspicion of Meibomian gland dysfunction. Next, please. So this is how we categorize. We use this approach, in which is how we categorize the MGD, stage 1, stage 2, stage 3, and 4, and the plus disease, in which something else is in the surface, like a demodex or something that we need to take in account. So why this is useful? Because that will guide us in the treatment, what type of treatment we are using. And until now, before we got the MGrx, we treat the same way, stage 1 and stage 2, with a straight like a stage 4. Now we can divide and stratify the approach for these patients. Next, please. So one more. You see in the treatment guide, the stage 2 is proposed that we use the warming and the expression of the Meibomian glands. And since stage 2, we can use that. But sometimes they feel there's very invasive using more complex treatment modalities. So let me show you what we are doing right now. Next, please. We already, as I mentioned, let me share with you this study that we presented at ARBO in 2017. And we started to do this in 2016, in which we were using the triple therapy that David actually mentioned at the beginning of the talk, and we use the debridement or scaling of the eyelid, the moist heat therapy, and the Meibomian gland expression. And we have really an improvement, a significant decrease in the OSD score, and the improvement in the tear breakup time, and as well on the corneal staining scores after 3-week therapy. In this type of therapy, we use 3 sessions, one at the beginning, next week the other one, next week the other one. So what we call it the 3-week therapy. So we have been using this for, as you can see, since 2016. Next. But now I would like to share with you our experience, and I really want to thank you, David, to allow us to have this here in Mexico, the MGrx system for the management of MGD related dry eye disease. Next. This is a really preliminary approach. Well, let me share you what with the first patient that we are treating. We treat 36 eyes from 18 patients. They were randomly selected, more on the incoming base, and then if we ask them if we want to have that. And the MGD grade was 1 or 2 as inclusion criteria, and I will show you right now after that what was the real figure. No age, actually, we have a large age group. Obviously, in all cases, we did a complete ophthalmological evaluation, and we use OSDI and mammography to evaluate this patient. And the majority, as you can see, were females, and the age group. You see the age range goes from 13 years, a very cooperative child, and 79 years old. The mean age for the female group was 45, around that, and a little bit lower for the masculine. But you can see all the different, the mean age is around 45. Next. Mm-hmm. And then the symptoms evaluation, well, we use the OSD-6, that is the fast one. And that comes with the knee check that I will show you device. And so mainly they have grade 1, 2, 3, but even 4. So the severity of the symptoms goes from almost no symptoms to really severe symptoms. Next, please. And then we have, well, we use the knee check for easy Meibomian gland screening, because in that case, we only use the lower lid evaluation, and provides an automatic evaluation of the Meibomian glands. So it's quite easy to use and does not take time. And as you can see, you can use it with your slit lamp. Next. And this is it. So we actually enroll only grade 2. The majority were grade 2 and grade 3, just one grade 1 Meibomian gland dysfunction according to the mammography. Next. So what type of patients we were seeing? My practice is a really corneal refractive practice, as David mentioned at the beginning. Most of the patients were from post LASIK. That's the one, 7 of them. But also the presbyopia and myopia were actually pre-LASIK patients that were looking for surgery. And the small ones, that's blepharitis and glaucoma. We have 2 patients of glaucoma. Next, please. So I just bring this study because most of the patients that I was going to show you were from a refractive surgery clinic. And we know that refractive surgery may aggravate the dry eye symptom. It's really a very common side effect, I will say, after corneal refractive surgery. Our results in Mexican population are in accordance with other studies that gender and age influence the risk of postoperative refractive chronic dry eye. But even though that there is an evidence that chronic dry eye is due to neuropathic factor, we found a correlation between the meniscus height, the break-off time, the average break-off time, and ocular redness, in addition to superior inferior meibography, the break-off time, the final first break-off time, and the average break-off time. So this association, awareness of this association, first studies, we need to understand better this post-refractive dry eye. Next, please. So I think David explained it and showed it wonderfully in the video, but we use this triple therapy modality, the debridement, the dry heat. This is very convenient, more comfortable for the patient according to them, and low, the time consumed for this is really lower, and then the expression that is also well tolerated, and this is the way that we do it. We from the side, and it actually creates this pressure over the gland to express the content of that. Next. So let me, the experience that I have talking with the patients, because I saw all the patients after they have the treatment the next day. I asked them if they tolerate pretty well without any discomfort. They say that was very quickly. They were spending more time in the treatment room. All of them that they have a decrease in the symptoms, although we are doing the follow-up for the month. We will collecting the data for those patients. And a very important question that I bring from my experience in refractive surgery is if they will repeat the treatment, and all of them say yes. They say that they feel comfortable enough to, if we need it, they can do it again. Next. What is the opinion of the technicians? Here, I have in my team, there are several nurses that help us in the treatment. That really liberate my time to see the patient, talk with the patient, and not doing the procedure. But as the same as the patient, they say does not require much. They say does not require much preparation time. It's very easy to perform, not time consuming, according to the same way that the patient said, and very convenient that they don't have consumables that have to change or interchange. That's just clean the different instrument that we use, and that's it. It's ready for the next patient, and that creates we have a very busy clinic on cornea, in particular in dry disease. Around 40, probably 50% of patients are dry eye patients in our cornea service. Next. And this is my own perspective. This, as I mentioned, this is a report of serious cases that is being followed. We need to complete the 1 month follow-up really to do, again, the mammography, the OSD, and all that. But I can see in our experiences, this type of therapy gives really good results in mild or moderate degrees of MGD. And I will show you a study on that. It's well tolerated by the patients. In the other one, the with the humid heat, it's not that well tolerated. It's very easy to apply in the office by the technician staff. That really makes our times more efficient, and it's very accessible. And both the cost of the system and the price, because that we can charge to the patient, because we don't have this disposable that creates an extra charge on the patient, and the number of patients that we can treat in a morning or an afternoon, or the time that we devote for the treatments. Next, please. And this is what I would like to share with you. We did this study using this triple therapy in evaporative dry eye using the cataract. The only difference with this, the MGrx, is instead of using dry heat. That is very convenient from MGrx. We use humid humidity. We use the blefa steam in that case. But as you can see in the study, and you can check it in the web, but we have an decrease in the number of symptoms according to the OSDI after 3-week sessions, and we improved in breakup time, the image of the Meibomian gland. So I'm expecting pretty much the same results with less intervention with the MGrx. Next. So we, as I mentioned just to show what all the different treatment options that we showed to our patient. Well, now we are considering, and we, as long as it's liberated after our clinical research, is part of our therapeutic strategy in what we call incremental complexity. We are seeing this approach very easy for, as I mentioned over there, we plan to use it in mild and moderate MGD in preoperative patients of LASIK, cataract, and glaucoma. Because it's very accessible, it's not time consuming. The patient don't consider that has an invasive treatment before they have the surgery that they are seen to have. And also, I want to bring your attention to geriatric population. It's really well tolerated with this type of patient. And I think this is another population that we are looking into, how to say, to promote more in that type of patient. And we are evaluating, since we have the experience with this young, early teenage or patient, really to see to increase the number of patients in that case. So we have as our first approach for MGD, the MGrx system, and then we can move to the other one, the blefa steam, and then has very more severe IPL or other type of approach.